So we've got the Parkinson's 5G. No pressure then, my goodness me, there's an awful lot of you. So this is your opportunity, having hopefully had a fantastic session today, to ask these brilliant set of experts, none of whom I know, a question. So I'm relying on you, Michelle. I do. You can't answer all the questions. It's not all about you. Sorry. That was harsh. So would anybody like to start with a question?
So over to Lydia. The question was, is it worth buying over-the-counter probiotic supplements?
So, I think it is worth taking probiotics. They obviously will help with the gut health, and especially if you have a disbalance in the gut microbiome, that will obviously help restore the gut balance. So in the long run, they are helpful. What do you think, Michelle?
Basically what I'm saying to everyone is, if you can't afford Simprove, go to Holland & Barrett and take some advice and get your cheaper options. There isn't the same evidence base as I've presented today for Simprove. However, what the Simprove say is they have a 4-strain microbiome, and ideally you'd like Holland & Barrett to give you the alternative.
And is Simprove available?
It's available, you can buy it online, and it's, I believe Parkinson's UK are discounting the rate there.
Thanks, Michelle. I think we used to. I'll have to check if we still do. We used to have a thing where members could get a discount. We do. Oh, we do. Oh, good. You know.
So I believe if you sign up for long-term prescriptions, like 6 months or more, how much is it a month?
I'm trying to remember. I think it's £40 a month.
There you go.
Sign up for a year. It's approximately £40 a month. If you sign up for a year and you give them your Parkinson's number, you can drop out of it if it doesn't work for you. So everybody else is committed to a year, whereas if you give a Parkinson's number, they'll let you drop out of that commitment. Myself, I've been taking it for 2 years. I lost my smell 10 years ago, and I've got my smell back.
And if you don't know how to become a member of Parkinson's UK, if you go onto our website, it will tell you it's free to join Parkinson's UK, and there's also Katie Slade here, well, she was in the room, Katie, who can help you navigate, and please join us and become a member. So thank you very much for the free shout. Laurel, you had a question, didn't you?
2 questions, actually. For very good reasons, clinical trials take a long time to deliver results. Partly that's to do with the analysis of the data that you've talked about today. Can you tell us what percentage of clinical trials are held up due to a lack of people with Parkinson's coming forward to take part? And my second question is, Ludo referred to the 4 subgroups that Michelle, I think, identified last year or previously. How much use do you make of those subgroups at the moment, and do you talk to your patients about them? Thank you.
Very good questions. In terms of how many Parkinson's trials are delayed or held up because we don't get enough parkies signing up, I can talk kind of to our Oxford experience, where we have a very kind of busy research portfolio of trials. I would say we don't have that problem with Parkinson's, do we, Jess? Because, you know, exenatide we recruited to target. In fact, for Parkinson's, the limitation is actually having enough staff to cope with the numbers.
However, this is a different universe, Oxford, and that is not true across the whole of the UK. So we know that only between 2 and 5% of people with Parkinson's take part in research trials. We know that the Ambroxol trial, which I think some of you may have heard of, which needs to recruit 300 people, it's a stage 3 trial, at the moment has only recruited 35 people. So we are struggling, and certainly some of the trials that we are sponsoring, we are getting participants from other countries rather than from the UK. And in fact, one of our trials, Top Hats, which is a UK-based trial. Again, it's a repurposed drug, so it's proved to be successful. It's very quick onto the prescription pad. We have struggled to get participants to take part in. That's specifically aimed at hallucinations. So again, I would say, apart from the please become a member of Parkinson's UK, please go onto the Parkinson's UK website, type in Take Part Heart, and think about taking part in research, because the only way we will find a cure is if people take part in research. And apart from in Oxford, and probably Cambridge, we are struggling to get participants to take part, and it's such a great way to get your health looked after as well as take part in research. So, you know, lovely to hear you're not having problems, but that is definitely not what we're experiencing across the UK.
So great, thank you, Caroline. And I think the reason we do well in Oxford is because the research is driven by clinicians taking it to patients. I think Ludo's going to answer.
Thank you for your question. Yes, so the second part being about the clusters, the 4 clusters that's been described within the OPDC cohort. And do we kind of use that in a clinical setting? I mean, the short answer is no.
Yes.
The short answer is it's not widely accepted that we stratify patients, you know, in a routine NHS clinic, you know, and tell them they have a mild, moderate, or severe disease off the bat, and kind of tell them, you know, you're more likely to get everything. We kind of have to give it a bit of time and wait for people to show their symptoms within the first 2 to 3 years, and then we can kind of more accurately kind of give them a trajectory. But that's kind of, in broad strokes, we can kind of characterize trajectories. But in terms of using our particular clustering approach, I mean, I suppose the question with the whole clustering and stratification of PD is, you know, how many ways can you cut a cake, right? So there's old ways that we've used to stratify patients based on their age or their gender, or their tremor dominant, or gait disturbance and kind of balance problems more dominant. But now in recent years, we kind of have a more data-driven approach, where you use a wide, you know, variety of both patient questionnaires and clinical biomarkers, you know, tests, to kind of distill these phenotypes. And broadly speaking, you know, and there are 2 or 3 other kind of proposals that have been made. Ours is by far, I would say, the biggest, and has kind of been externally validated in the second cohort. But do these clusters, are they reflected in all Parkinson's patients, you know, globally, and is that kind of considered standard practice? No, not yet. We're not there yet. So I'm sure we shall have some more to add. But I suppose I think that the take-home maybe on some level is and it's, you know, again, we must be careful, of course, to kind of put an idea in your head and say, well, based on this, this, and this, I must have the severe version, and that kind of really puts you down. I think there's a lot of individual variability, and there's a lot you can do to kind of change that trajectory. So it's important to kind of, I think that's also a reason why we tend to be a little bit hesitant about putting people into boxes, because, you know, you don't want to kind of put something in someone's head of like, you've definitely got the mild version, and then they're disappointed, or you've definitely got the severe version. So, but I would make the last thing I would say is that generally, kind of what we kind of tend to see is that the degree of non-motor burden of symptoms, right? So not the motor symptoms, but the autonomic symptoms, the cognitive symptoms. If that's very prominent, very early on, that tends to mean that your Parkinson's might be a bit worse. There's things like being a woman tends to be better. Having earlier onset tends to mean slower progression. So there are these trends that we see, but it is still difficult to kind of categorically stratify Parkinson's.
The only bit I'd just add, Laurel, is that cluster 3 has poor sleep, i.e. RBD, daytime sleepiness is worse, and worse cognitive function and worse quality of life. And when I'm telling patients why sleep is important, we are almost thinking of sleep as a medicine. So by treating restless legs, by treating RBD, sleep will be better. And what we don't know is what effect is that going to have on your daytime quality of life and your daytime memory and cognitive ability. I think it's positive from anecdotal reports. The other thing is cluster 3 have higher rates of people with the GBA mutation. And if you've taken part in PD Frontline, you will have done a saliva swab and you'd have had your saliva cells tested for GBA. And I tell patients if they've got a GBA mutation and what the consequences of that are, if they want to know. meaning faster progression and unfortunately a higher risk of future dementia and running into motor complications earlier and needing things like deep brain stimulation earlier. But you have to know that the person you're talking to wants to know the information first because they're going to do something about addressing their risk.
Okay, any other questions, lady here?
My name is Sue Hester and I'm a retired nurse practitioner. A recent study published in Science Direct in July indicates nocturia and nocturnal polyuria are associated with orthostatic hypertension. Some drugs prescribed for Parkinson's disease have OH listed as a side effect. Nocturia and polyuria are burdensome symptoms which are associated with sleep deprivation, cognitive impairment and dementia. I could find only 3 studies published on this issue, and as 50% of people with Parkinson's develop dementia during this time, doesn't this warrant more research into this issue?
I'll take this, Michelle. You're welcome to add. We are looking into, we would classify bladder dysfunction with constipation, orthostatic hypertension as autonomic dysfunction in prodromal, but also in Parkinson's disease. And this is in our top 5 next projects to do, is to look at how autonomic dysfunction fits into the Parkinson's spectrum, because it ties up with what Livia said earlier. We think it's part of the body first disease pathology kind of hypothesis through the vagus nerve, which plays a significant role in autonomic function. So yes, it's on our priority list.
Hello, and I just thought I'd grab the opportunity to say that that's actually also a theme that we are looking at together with Parkinson's UK funding. So because I lead the imaging theme, and we've just been funded for another 3 years of running imaging. In particular, we're going to look at how people who are on the trajectory, so prodromal Parkinson's, how they develop autonomic dysfunction, what that looks like. So we're going to do that with really expensive scans, but the idea behind that is, that's not something you can do widely, right? So all that imaging is great for research and for, when you're trying to set up a trial, but you're not going to do that with everyone who walks through your door. But the point is, what we're trying to do really is to validate other measures that are much more achievable, like for example your heart rate, your sleep, that you can measure with one of those modern watches, and translate that into, from something that's only achievable with a nuclear imaging scanner to something you can do at home. It's the whole idea behind that. Yeah, so I should say that we've just been given £330,000 of funding. Yeah, that's thank you.
And I think such a good point, and these kinds of issues that people are dealing with, it's so important that people like yourselves are involved in making the decisions about what we fund. And if we don't understand what's most important to you, we won't be able to fund the right research. So if you want to get involved, come and have a chat.
Great. So gentlemen down the front, please. I've got 2 gentlemen down the front. Well, I've got more than 2, but I've got two that want to ask a question.
I've got Parkinson's for 10 years. I actually did a degree in statistics, and looking at what you've done, it's amazing. I spent 3 years working on statistics, and the way you marry data together and the way you compartmentalise and produce clusters, very, very impressive. My only concern is that, if I'm being slightly controversial, possibly, is you haven't really said what medications have been shortlisted, are likely to succeed, and in many ways that is more appropriate for me than enjoying some of the statistics that you've done.
Tanya? Did you want to address that, or do you want me to?
I think it's a medications question on the stuff.
Do you want to?
Yeah.
I think I'll probably say what other members of the panel would say as well. Are you essentially referring to what kind of drugs are there in the pipeline?
Yes.
Yes, for Parkinson's. I mean, I don't have an exhaustive list, but kind of off the top of my head, and I'm sure the other members of the panel might be able to add. But so we've done, like Padova has been running at Oxford now for the last 18 months, almost 2 years, where they're using an antibody that kind of attacks the alpha-synuclein, the protein that's in question. And kind of preliminary results have not been as promising or as hopeful as they would have liked them to be. It's kind of on an open label extension, so the jury is still out as to how effective this drug will be, but the hope that it would kind of be as effective or as big of a kind of turning point as a similar variant of what this drug was in the Alzheimer's sphere is probably not on the cards, but maybe it's still too early to tell. I mean, then there's things like Ambroxol, and they've run exenatide recently, unfortunately, again, not as promising as we would have liked it to be. So, there are certainly drug trials running, and Michelle might know of one or two more that we are getting involved with. I know that with the GBA mutation-related PD, we're also getting involved with something.
So we did look at medication benefit in those 4 clusters, and what we did was, firstly we rated response to levodopa. So 90% of the participants, this was within 1.2 years of their diagnosis at baseline, 90% were already on levodopa or dopaminergic treatments, and we rated their benefit using the patient-related, how much does it improve, but also on a formal levodopa challenge. And we found really interesting that cluster 3 was actually on a much higher dose of medication because their symptoms are worse at baseline. And we found that levodopa benefit, measured with the levodopa challenge, was best in the most benign cluster, cluster 2. So far we haven't got any symptomatic treatment that's better than levodopa, and I think that it predicts, if you get good benefit, it predicts a good outcome, i.e. you're slower to progress, to both motorically and cognitively, and if you're going to be on a higher dose, it's probably because you don't get as much benefit and you're asking, because you're struggling and you're more disabled, you're going to be on a higher dose. How long your medication works for you before it starts to wear off or become less effective is also something that we're developing in our prognostic index, because that's what patients tell us they want to know.
I thought of one thing to add, maybe that links, I guess, your question to some of the stats that me and quite a lot of other ones touched on today, which is that a lot of the interest in developing these improved motor measures like the neuromotor pen, the smartphone app that Katharina and Timothy talked about, a lot of it is of course about monitoring symptoms and helping counseling in clinic, but it's also about getting outcome measures for clinical trials which are statistically better in that there's a better, I think the statistical term would be a better signal to noise ratio, so that in the end if you use these outcomes, if they are properly verified, you can do statistically sound trials with fewer participants for a shorter duration of time, and you still know reliably if a potential new treatment has an effect or not. So that's where stats links into trials, I think, quite strongly.
Yes, there's been talk of gut health and diet and physical, the benefits of physical activities, but there's no talk of mental health. And I wonder whether we should be doing our daily crossword or our Sudoku or whatever. Is that going to be helpful?
I mean, that links nicely to the earlier question, because, I mean, it is true that the space of developing new molecules is difficult in neurodegenerative disorders like Parkinson's, but our practice has definitely changed over the years, I would say, because it turns out that what you're saying is, well, that is what drives the disability in the first 5 to 7 years when you're diagnosed with Parkinson's. It's not the motor symptoms. You take your levodopa, you're fine. It's the apathy, it's the depression, it's the anxiety, and, could be the cognitive problems as well. But we've learned that there are drugs that help with that, and so we basically steal from the psychiatrists and we use their approaches in our service now. to better service people with Parkinson's disease. The question whether a Sudoku helps is probably not, so we can't really say because I only know data from Alzheimer's, not from Parkinson's. But what we do know is that interacting with other people is, protective, and physical exercise is protective. So, goes back to what Helen said earlier. It's not just about falls, which obviously is one of the most important things, because before you break your hip, then, and the whole shebang. But it's also about cognitive health, and we know from the available data that people who stay physically active have better long-term outcomes in terms of cognition. And when you look, there's a recent meta-analysis on depression, not in Parkinson's, but just depression. And do you know what the best intervention for depression is? It's not a drug, it's dancing. Yeah. So, of course, these things, the statistician will probably criticize the number of participants in these trials, but the effect size of just getting somebody out to dance, just think about it, you get it all in one go. You have the physical exercise, you get to interact with other people, you're forced out of your comfort zone, and all of the above. Yeah, so, yes, go dancing, folks. So you're right. It's the biggest drive of disability in early Parkinson's, and we do deal with that.
It's a really good opportunity for me to plug something. Is anyone here coming to Parkon? I know Laurel and Peter are, amazing, Sally, lovely. Has anyone not heard of Parkon? Oh, fantastic. So Parkon is our community, flagship event for the Parkinson's community. We're doing it in Birmingham this year on the 24th and 25th of October. In-person tickets have sold out, but we have unlimited space for you to all join us online, if you can join us virtually. We'll also be recording it. We will have sessions on diet and nutrition, mental health is a whole session, because it's so important. We'll have a session on what's in the pipeline, treatments for Parkinson's, not just in the UK, but internationally. And we'll be having dancing with Angela Rippon. So it's everything you could possibly want and more. It's completely free to attend. So please, it's all over our website. So please have a look and join us if you can. We'd love to see you there.
Thank you. Any more questions? So I've got a gentleman at the back, and then 2 questions here.
Hello. I started a Facebook page on RBD, and it's got quite a lot of international usage. The Australians, some states in America and Canada use cannabis to help the RBD. What are the chances, or is it any use? And what are the chances if it's sort of being available here?
Well, there's lots of awkward faces with that question. So Michelle,
I don't have the answer specifically. But I do note that many people with RBD will say that their RBD frequency is much worse when they're personally under a lot of stress or pressure. It seems to trigger increased nightmares and more violent content. We do know that cannabidiol, which is the sort of medical derivative of cannabis, can help for some symptoms of multiple sclerosis, so we're allowed to prescribe that, for example, for leg spasms or cramping. But cannabis itself, we can't obviously prescribe, and even the sort of more derivative forms of vaping. So I think it's a big unknown. I am aware that there is a cannabis trial ongoing in Parkinson's psychosis. So I think the honest answer is we need more information, and I'd just be a little bit concerned about tolerance and also drug-induced psychosis with sort of unregulated forms.
Yeah, just to add to that, there's 2 cannabis products that are licensed now in the UK. Well, the cannabidiol is used for Dravet syndrome in particular, so severe childhood onset form of epilepsy with poor outcomes, so young death and all that. And there is actually cannabis now as an inhaler. Of course the pharma company had to make it an inhaler, and that's used for spasticity in MS. I don't think there is much that we can say because we don't have the data, but there has been, I think a lot of political movement there when people were offering opinions on how it helped their back pain, and that's why cannabis should be a thing. I think, I'd be very careful with these drugs because you don't know what you're getting, and, as Michelle says, that stuff drives psychosis, and that's not what you want.
Okay, so there was a gentleman behind and then this lady here, and then I'm going to have to draw it to a close.
Good afternoon. Working on the principle that prevention is better than cure, what efforts have been used to educate general practitioners about RBD? They are the first contact with the national health system, and then on to yourselves usually. So what is being done there, please?
I was about to throw the question back at our colleagues from Parkinson, because we can only do Oxford.
So, yeah, I agree. I think nationally, GPs do not recognise REM, sleep behaviour disorder, or RBD. In fact, Annette Schrag did a study where she looked at all of the GP's symptoms that were recorded in the 10 to 20 years before all of the patients on the CPRD database, which covers about 70% of everyone in the UK, developed Parkinson's. And RBD wasn't there. And this was 10 years ago, and everyone went mad going, you see, Michelle, RBD is all not generalisable to the general population, but it's actually not recognised. In Oxford and nationally, I have done talk after talk, mainly for future GPs, through medical school, medical students, teaching them about RBD. And the best way that you teach them is by showing them a video, and then, 10 minutes of simple science and explanation and treatment, because it's a very rewarding condition to treat. Sleep specialists like Luca are in a minority in the UK. Access to sleep clinic, access to sleep diagnostics, it's often a year wait. So it's an underserved medical specialty, I would say. And I think one of the things I would love to do is set up a patient support group for the UK and nationally and internationally for RBD. I think that will actually educate people, and it will tell them how they can get diagnosis, how they can be treated in the research options, and they can be a research database. So if anyone is interested in helping me to develop that, I've been meaning to do it for 15 years, please come and see me.
Brilliant. And finally there.
Janet Urban from Swindon, diagnosed 15 years ago and going strong. We're in a centre of excellence, and this local services are good, both here and in Swindon. But that's not the case across the country. How concerned are you overall about the availability of Parkinson's nurse and Parkinson's specialist?
I think, I'm in the, let's say, interesting position of being the clinical lead for neurology in Oxford. So the reality is that when you look at how funding in the NHS is moving, it's going towards episode-based specialties, or anything that you can fix and then you discharge the patient, gets money, and neurology isn't like that. So neurology and rheumatology are specialties with a lot of chronic disease, and that is, unfortunately in the current funding of the NHS, it's not happening. Yeah, so we don't get money because we accumulate patients, so we only get money for new patients, not for follow-up patients. So that's a very difficult question. To put a more positive spin on that, so what we have in our department is GPs with a special interest in headache. Yeah, so we have some GPs that see headache patients for us, and across the country there are also similarly GPs with special interests in epilepsy and Parkinson's. So I've spoken to a few of those, and there are national meetings online these days about about exchanging ideas and how to actually make this work. Now, we all know that the number of people living with Parkinson's is going to rise simply because of demographic change and a few other factors that are less important. And there is no way that neurology can keep up with that because we're not educating enough neurologists. So here you've got a few sitting here that we're training. But the point is, you're training the same number of people and there's more demand. Yeah? It's not going to work. The bottom line is, if you want my view on that, what will need to happen is that we have better means of actually helping people, better means of having remote monitoring, so where smartphone apps come in, and that you then empower people in the primary care sector, nurses, GPs, to actually serve patients with Parkinson's, because it has to go that way. If there's no money coming, then there's no other option for us as a country to deal with that.
So 2 examples that you've seen presented today of this digital smartphone work could be embedded into routine NHS clinical pathways. This 8-minute smartphone test is now available for people to download on their own smartphone, whether it's iPhone or Android. This is separate to the research bit that we use with separate research ethics and consent. And what that would allow the GP to do is ask the patient to do that at the time that they make the referral for this person's presenting with a hand tremor, is it Parkinson's? That will then stratify the top 10% who performed the worst on that test and are most likely, by our predictions, to have Parkinson's. And also, not just that, stratify based on the fact that we can predict if they have a normal or an abnormal DAT scan, which is one of the tests that helps us refine the diagnosis of Parkinson's. And lastly, stratify people who are on the route to faster progression from their Parkinson's. So we would then be able to prioritise our waiting list, which is currently 12 months, into those in urgent need of being seen in 6 weeks, which is what everyone should be offered, versus being seen in the next 2 months, and then versus we'll have to wait because this is unlikely to be Parkinson. We also have a pathway where people could be monitoring their own symptoms following diagnosis or treatment, and having that being fed back to them through the new health app in real time, and saying you're doing really well. You don't need to change your medication, you don't need to do anything else, you just maybe need to see a Parkinson nurse or specialist once every 3 years, or when you say you need to be seen. So there are ways to reduce the burden of the NHS, and we have to change with the times.
I've got a slightly different lens on that. I've met a lot of people who aren't digitally enabled. So I think it's great to get pathways where people can use digital means to manage their healthcare. But the truth is 30,000 people with Parkinson's do not have access to a Parkinson's specialist nurse. I met a lady called Shafak Hussain Ali, who probably some of you may know if you saw a photograph of her. She's a dentist who has Parkinson's, who hadn't seen a Parkinson's nurse in 6 years. She lives in Sheffield. I met a guy on Friday, who lives in Mid and South Essex, who has seen a consultant once, and he was diagnosed by that consultant 4 years ago. So actually, whilst it's great that we've got people who are looking at ways to improve access, actually getting the access to start with is a huge problem, and we can't be quiet about it. We've been quiet about it for too long. So, I know a number of you will know the movers and shakers, and for those of you that signed the petitions, thank you. We look forward to a debate in Parliament, probably November time. Will it change anything? I don't know. But what I do know is if we keep quiet and we don't say anything, absolutely nothing will happen. And it's not just Parkinson's, it is neurology services generally, which are definitely the Cinderella of all of the services. And I think the point that you made is completely right. If you can fix it, that's where the money goes. If you have a longer term condition where at the moment there isn't a cure, actually the NHS does not put funding there. So we do have to do everything both locally, and I know there are some brilliant local campaigners who have really kind of stopped things happening in their local hospitals that were planned to happen. But we all have to work as one community together, both looking at the innovative solutions, but actually banging the table and saying there aren't enough nurses and there certainly aren't enough consultants.
In the current climate, that we've been given another consultant, I think that should be a big, we should make a big
difference. Yeah, and thanks for your help with that, Caroline.
But this is a unique. If you are under, or you live in Oxford and you have the privilege of being under Michelle and her team's care, you are really in a privileged position. And what my view is that everyone in the UK should be in that position. So if you could increase your waiting list, there's 166,000 would be great for you to see. I recognise what the time is, so I'm going to ask Michelle if she'd like to make any closing remarks.
So just thank you for coming. This is, I can't remember whether it's our 10th ever cohort day, but I think they've just grown in terms of engagement, interactive, discussion and attendance. Thank you so much for coming. The talks will all be made available on our website, so you can always go back and you can read that or watch it again. And do sign up to our research on your way out, or take a form that you can post back. Safe journeys home and stay well with your Parkinson's.